This presentation was recorded at the 12th International Conference on Rapid Response Systems and Medical Emergency Teams.
Thank you, Bernard. I'm delighted to be here for the 12th year, and hopefully there's more to come. I'm going to take a bit of a contrarian view, and you'll see why in just a moment. And I'm going to speak a little bit from personal experience, and I'm going to be talking about a couple of truths. I don't know whether these truths are true or not, but they're true to me, and we'll see if they're true to you as well. The first is the triggering criteria, whether you're using Muse, News, the single parameter triggering systems, doesn't matter. RRS patients, the ones destined to live, are identical to or at least very similar to the ones who are destined to die. And so the RRS triggering criteria will necessarily identify both patients who are dying and those who are really sick but are going to live. The second is, and I think the previous speakers talked about this a little bit, this is very old data from Karen Steinhauser, but I think it holds true today, is that what doctors think patients want and what patients want are very different. And what doctors want for patients is different from what doctors think patients want. And that's an important distinction that I'm going to come back to later, that we need to be pretty humble about trying to decide for people what is best for them, because we're just pretty bad at it. So how do we find out what people want? You need to do communication, and the question is, are we good at communication? I think there's just a zillion studies now talking about how we are not good at communicating with families, either in terms of the content or the timing, and that's been alluded to already today. We did a study at Pitt where we looked at patients whose predicted survival was less than 50%. I spoke about that this morning. Patients who are readmitted to ICU, patients who have already had a cardiac arrest, patients who have been in the ICU for 14 consecutive days, and so on. And we found that only 10% of those patients had a conversation about goals of care. Keating and Curtis have found very similar findings. Those pictures over on the right side of the slide regard when is the appropriate timing for having a conversation regarding prognosis, hospice, DNR status, or the site of death. And the different bars represent now, when the patient first develops symptoms, when there are no more non-palliative treatments that are appropriate, only if the patient is hospitalized, and only if the patient or family brings it up. And the actual ratios aren't important. Just look at the differences that are there in terms of people's attitudes towards how they approach when the conversation should be. It's way easier to predict what's already happened than it is to predict what's going to happen. And by that, I mean that all this wonderful predictive data that we've talked about and the news criteria and some of the newer technologic advances for having very good area under the curve values for predicting mortality during this hospitalization, those are still just probabilistic. They tell you that your risk is 90% of dying or 20% for dying. It doesn't actually say whether you're going to die or not. That's a 1-0 proposition. That's not probabilistic. And we don't know that. We can get close to it, but we don't actually know what's going to happen. And I think all of us have a bit of trepidation about the uncertainty involved in talking to any particular patient. And the patients have this same trepidation about talking about my end-of-life care if I'm not certain whether I'm going to die. I think once it's obvious that somebody is actually dying, it's a lot easier to have a conversation about how they're going to die than it is way beforehand. And that's important because goals and decisions change with time. So anybody ever have a nasty conversation with somebody and then you say, next time I have that kind of conversation, this is what I'm going to do? How many of you actually do that? And it's not common that we say, I'm going to punch that guy in the nose, and then you actually punch the guy in the nose, or you have that snappy comeback. And that's because we perceive risk and benefit differently when things are actually occurring and when they are proposed to occur. And there's no way around it. That's a human foible, that the way we think we'll behave is very different from the way we will actually behave. And in part, it's the uncertainty, and in part, it has to do with the acceptance that go on. So as a result, I think all the different predictors of when we should have a conversation about end-of-life care is a bit difficult because of the uncertainty and the way we decide that we're going to have conversations and the way families and patients are ready for conversations. But an interesting thing happens when an RRS event occurs. These are events that are mimicking end of life, and most of the time will be end of life if we don't intervene. So it becomes an ideal opportunity to take a person from that uncertain, what am I going to do next time if, into the present. Boy, you just dodged death, or you are about to die, or mom is about to die. How should we proceed now? And it makes very concrete what had previously been nebulous. And I think it is a great opportunity because it makes the hazy tangible. It creates a bit of a time pressure. Most of these conversations don't take a long time, but they do require some efficiency and tact, which I'll come back to in a moment. And it's a natural opportunity because both the patient and the family are wondering, is this it? And so there's a good opportunity to say, yes, this can be it, or no, it doesn't have to be it. This isn't written anywhere that I know of, but in my experience, I think I've broken down all interactions with patients or families into 4 conversations, which are linked but distinct. The information exchange conversation is one where we're just trading data back and forth. I used to think of this as a bad news conversation, but I stopped trying to figure out what bad news was. I'll give you a great example of a statement where you don't know whether it's bad news or good news. You're pregnant, right? It could be really great, or it could be really horrible, or it could be meh. And you don't know. The important content of that is not whether it's bad or good, but it's that it's important, and it's something that's worth discussing. And there's a bidirectional arrow there because not only should we be telling patients and families about what's happening now, but they need to tell us about what's important to them. These should be bidirectional conversations. The second one is emotion management. So I can go into the room and talk to somebody, and I'm not an obstetrician, so I don't have this conversation often, but you're pregnant, you have to be prepared to have a discussion regarding emotion management. And this happens a lot in the ICU, and it's usually due to sadness. It is commonly due to anger. But if you give somebody a piece of information, it is very important to be able to help manage the emotion, both in the patient and family and in yourself. So if I make a mistake that results in somebody having a near-death experience, I have my own emotions that I need to manage as well. And it's important to be aware of the emotions. And there's a whole literature on this. My favorite mnemonic is NURSE, which is name it, understand it, respond to it, support it, and explore. And you can look this up, and it's a great way of teaching young physicians and nurses how to manage emotions. And if you just name it and say something in an understanding, you don't want to tell people, I understand what it's like to lose your mother, because your mother is not as good as their mother, I promise you. But to say something in the understanding, nobody can understand what a big loss this is for you, or how tragic this must be. That goes a long way to helping diffuse the emotion. Conflict resolution. This is when either members of the healthcare team or members of the family or members of the family and the healthcare team have conflict between what they are understanding or what it is they want to do. And a misunderstood way of managing conflict is not necessarily to negotiate, but to redefine the facts. 95% of conflict in the hospital environment is due to not understanding the facts the same way. And so we've talked about, get all the doctors there together or get the nurses and the doctors together to have a conversation before you go to the family or have the family together. That is a method of making sure that everybody understands the facts the same way. And then there's decision making. Where you actually make a decision. What am I going to do? Now, there's a hierarchy here. And the biggest mistake I see junior trainees and inexperienced people is they go to decision-making before they've worked through the first three. If you don't understand what the facts are, if you haven't managed the emotions, if you haven't resolved the conflict, there's no way you can make a decision. And it's very important to, at least as I'm training my house staff, to make sure that they break down every conversation. If they're going to have a decision-making conversation, you have to do information, emotion, conflict, and sometimes there is none. I've had conversations with family where I've gone in and said, I need to have a conversation with you, sit down and say, I think mom's dying, and this is really going to be it. And they say, oh, thank God. She's been suffering for years. We've been waiting for this. You're the first doctor to actually tell this to us. We've kind of recognized, and I'm so happy that you're giving. So you don't have to really have an emotion management conversation with those people. But knowing that the emotions are managed, there is no conflict here, enables you to jump straight up to decision making. On the other hand, if they say, that's horrible, you're a terrible doctor, now we need to backtrack and deal with the emotions, make sure they understand the information well, deal with the conflict that may be unresolved. Once you have done all that, then you're sort of on the same side. You're on the same ball team as the other side, and you can get to decision making. This is out of place, I'm going to skip it. So when we make decisions, there is a tendency to talk about the thing that you're, the intervention that you're going to do, rather than the goal that you're trying to attain. And I think this is rather like going to a travel agent and saying to them, I want to take a car, right? How does that make any sense, right? So I don't want to use a ventilator, I don't want to use a car. That might make perfect sense. There might be some people who just don't want a car. They just get car sick, right? And so for them, it doesn't matter where they're going as long as it's not in a car. It seems to me to make a lot more sense to say, I want to go to Paris, or I want to go to Perth, now that we're in Australia, and then have the travel agent say, okay, well, if you want to go to Paris, you can't use a car. You can use a plane, you can use a boat, but it'll take a long time. But car is out, walking is out, swimming is out, it's too far. And starting with the goal, what am I trying to achieve, actually limits the actual choices, the interventions that you're going to do. Now, there are people who don't want particular interventions, and you can find that out in the information exchange conversation. I've had families say, I saw my father, he was on a ventilator, it was horrible, he hated every day. I don't care what you do, but ventilator is not part of it, okay? That makes some sense to me. Their goal, actually, is to avoid the horror that dad had for mom. So we have to break down, we should be thinking outcome rather than intervention. And then once you've defined the outcome, it becomes actually fairly easy to talk about the different interventions. Some goals can be interesting. I've had patients say they can die any day but next Thursday. Well, what's next Thursday? Well, that's my daughter's birthday, and I don't want my daughter's birthday to be associated with grandma's death. And some it's been Christmas, some it's been I have to live past Saturday because Saturday is the wedding. And exploring the needs that patients have, it can really be very helpful. There's a vocabulary that goes along with this, and it's important to have a repertoire of 2 or 3 things that you want to say that can help you either support people through this crisis or break the ice. Saying, I think mom's going to die may not work as well as I'm concerned that your mom is going to die, or it just doesn't work as well as dying. It is important, however, for you to use the word die, dying, or death in conversations fairly frequently. None of them have 4 letters, but they're all 4-letter words because you say them in polite company. It is really important, even if you think somebody's going to survive, it's important to use the word death because they are thinking death even if you're not thinking death. And a nice way about it is, this last one is actually particularly good. I'm concerned about how you're going to do if your mom dies, because it gets back to the probabilistic, vague notion of mom dying, and it's concrete on them. What are you going to do? It helps them formalize in their own thinking, all right, so what am I going to do after death? And that foreshadowing of how am I going to exist after death is very important in palliative care to help people accept the inevitability of the dying process for the individual. We need to support the patient, and there is language for that as well. I want to give you the best care possible. I want to ensure you receive the care that you want. I'm worried about how you're going to manage, and so on. And these are important because it enables you to talk about outcomes that are not necessarily life and death. You can talk about the other outcomes that we may not even be aware of. I'm going to describe briefly. Do I have another minute or two, Bernard? I got asked to speak at an ethics conference, and the question was, a patient had been intubated and extubated several times. Each time extubated had had a small aspiration requiring reintubation. The doctors just got the patient re-extubated, and the patient was on the floor, and both the patient's son and the patient were refusing nasogastric tube feeding. Everybody agreed that it was important that the patient be fed, and the son was saying, do not put a feeding tube in, but you absolutely have to feed the patient. So they got a speech pathology evaluation, and it was clear the patient was aspirating, and the doctors and the nurses refused to feed the patient. And this fight went on about what they should do. It didn't actually sort out until after they had had the conversation with the son. You know that if your mom eats, she's going to aspirate and she's going to die. And you've told us that you don't want her intubated again, so we don't want to feed her. And he said, I know that, but she's going to die probably during this hospitalization, whether she aspirates or not. She's dying. And for us, it's more important that she has food presented to her than she actually eats it, or if she aspirates it. That is part of our human experience. Food is important to us. Giving her food is more important than if she eats it or if she aspirates it. Now it makes sense, right? But it didn't, from a medical context, it can be very difficult. So it's worth spending the time and trouble to learn why. And it doesn't have to be logical according to your standards, as long as it's logical according to their standards. Now, you wouldn't want somebody to say, I don't want you to resuscitate my mother because purple is Tuesday. That's nuts. On the other hand, if they say, I don't want you to resuscitate my mom because of something like I just described, please feed my mom because of this, that makes some sense. And so as long as there is some sort of rationale for it, even if you don't ascribe to it, it is probably a valuable thing. And we need to realize that our wishes may be very different from what the patients want, and we have to be willing to accept that we're wrong in what we think is best for patients. Thank you very much.